Chúng ta cũng chờ ra mặt và đọc của y khoa phòng thật không ạ? Sau các bài trình báo cáo rồi. Dạ.
Ladies and gentlemen, our final speaker today is Jennifer Grace, Mid-Song Chancellor, and Dr. Jennifer is a specialist prosthodontic from Australia and a senior lecturer at University of Western Australia, and she also working in a private practice in Perth. Today she will be the final presentation of our conference. And please welcome Dr. Jennifer Chandler.
Thank you so much, Becky. Thank you for staying to the very end. This is the last one. Hopefully I can impart something for you that you are interested in, and I hope you learn something from it. So this is the lecture on clinical tips for successful outcomes in prosthodontics. Before we get started on the clinical side of things, I wanted to acknowledge some people, and you will have your own people in your life, your mentors, my teachers, the people that have taught me along the way. And these mentors from my colleagues, Dr. Chris Evans from France and Alexis from Switzerland. I was able to connect from Australia all the way to Europe, and a huge influence on how I approach dentistry today, as well as research, not just your technical skills, but how to think critically and question what you're doing whilst you have the patient in the chair, and really enjoy this process. I think one of the biggest things they've taught me is that clinical and research shouldn't be separate, but you should combine the two, and that's when things become really powerful. And honestly, that's where I find the most satisfaction in what I do. So I'd like to say thank you to the National Hospital of Odontostomatology for inviting me here today, and I hope together we are now friends and colleagues, and we are able to share our information to each other. Now, I was fortunate enough to spend the week with the high-tech department and the prosthodontic department, and I believe we are now friends, and my friend group around the world is growing, so I include Vietnam in that too. And we can't forget my friends up in the interpreter's box, and I'll do my best to speak as slowly as possible so that you'll be able to understand me. So everything looked fine until one day the patient realised it didn't. And the solution I found is it's rarely just to crown the teeth. It's the decision before the crown. In this case, on the surface we can see generalised tooth surface wear. So the teeth are short. We have a loss of vertical dimension missing, some erosive acid, maybe even some grinding habits. And what I want to walk with you today isn't just what I have done for this patient, but it's the decision-making process behind why I've done what I've done. And I'll apply what I'm going to tell you each day in clinical practice. Each day, what I'm doing is I'm thinking through all these steps so that I am able to give you a case and an outcome that with proper planning can become predictable, even though sometimes outcomes are not what we expect. So why do cases actually fail? It usually comes down to two things. First, it's the wrong tooth. We misjudge the prognosis. We misjudge how important this tooth is. We can overestimate that the tooth can tolerate. And the second is we don't have a backup plan. We've committed to something that we can't back out without thinking about what happens if we lose this tooth, or when this fails, or when the patient gets old, or when the patient can no longer all of a sudden develops high caries when he was once healthy and young. So once you're down on a pathway that is hard to unwind, especially when restorations are complex and expensive. So the reality is most failures in my hands are predictable when I first see the patient. It's not at the preparation or the cementation step, or not even what material I choose, because we have already built into the case from the very beginning with the treatment planning. So the goal isn't just to execute your plan well, but it's also to think better and earlier. So often I think our roles as prosthodontists are builders. And I'm sorry, Sony, but prosthodontics is the best, okay? And the reason why I say that is because it may seem that we are just placing crowns and designing restorations, but we are responsible for the whole plan. And we're looking at the structure, the sequencing, the longevity, how everything comes together over a long period of time. But just like the builder, the outcome is only as good as the planning that happens before anything is constructed. So no builder works alone, right? You've got your plumber, your electrician, you've got your carpenter, or in this case, endodontist, periodontist, maxillofacial surgeon, orthodontist. And while we might not be the ones to do every procedure, I need to understand what each is capable of, and we need to make sure that we can achieve realistic outcomes. Where limitations are, where we know we are expecting too much, and how the work of the other specialties impacts our own. So I actually got into prosthodontics thinking I never have to worry about another specialty. I never have to think about orthodontics or endodontics, but I'm really starting to understand how critical it is to really have a grasp of all the other specialties, and how much, for orthodontics example, how much movement is possible, how quickly we can do these things, how predictable it can be, and so we can start to prepare the patient at the very start of the treatment so that we can come up with a treatment plan that we can at least be on sequence and predictable. So when we look at a case, it's easy to get caught up with just this one tooth in front of us. Either it's fractured, or the crown is failing, or we want to place an implant. But the reality is we are treating a patient. As the teenager becomes a mother or a father, becomes a grandparent, becomes a great-grandparent, we need to consider what it's like to be through all ages. Our job isn't just to fix this one tooth, but we need to make sure that we manage this dentition for their whole life. And the goal is actually very simple. I need to get teeth, or as many as possible, to last as long as the patient. And I am thinking about this every day for every person, every time I'm picking up my hand drill to do a filling or a crown. I need to make sure this tooth lasts, or I do my very best to give it its best shot to last until they die. So when you start thinking different questions, it's not just when can I restore this tooth, but should I restore this tooth? For how long? Do you reckon it will last 1 month, 10 months, 1 year, 5, 10, 20 years? But what happens if it fails? And this is where risk assessment becomes critical, because every decision we make either adds time to the journey or it takes it away. So I've put together this flow chart, and this is exactly what it hasn't come out of a textbook or anything, and it's very complicated. We'll go through it all, but it's not just a rigid framework. It's just a framework to help guide your decisions when you see a patient, when you see a tooth, and what to do. So the first aspect of this flow chart is the restorability. Is this tooth restorable? And it's not just, can I physically put a crown on it? It's, does this tooth have a predictable long-term prognosis? Can I get this tooth to last 20 years? Do I restore it, or do I just temporarily stabilize it? Or should I plan for a replacement? And the key thing is that I'm not just making this decision in isolation. I'm making sure that my choice has a consequence. If I keep this tooth, what does it mean for the plan in 5 years' time? And if it fails in now or in 5 years' time, does this plan change my overall plan? Now, we've all, I'm hoping, has seen something like this, the restorative cycle. And at the center of this is one thing, tooth structure. We all start with unrestored teeth. And as dentists, with our own teeth in our own minds, I think we can all agree that we get very nervous when we need a filling, when we need a crown. Oh my God, if we need a root canal. And better yet, I'm not sure if you have dreams, nightmares of having full dentures. That has definitely happened to me. So every time we intervene it, we need to make sure that we know we are removing some tooth. And when we remove tooth, we cannot get it back. So I like to call this the restorical cycle of death, okay? A tooth starts with a small restoration, it becomes a larger restoration, it becomes a crown, and then maybe endodontics, maybe a post, and then eventually failure. So I think we can all agree the more tooth we have, the better prognosis. So every preparation I do, I'm thinking about how much tooth structure remains and how many times I can do the same restoration and how much tooth am I removing. Now this takes to a beautiful study which I think you should all read. It's very nice, simple study. Edelhoff, he is a prosthodontist in the Netherlands, and what he has done, he's done an in vitro study, and he's taken just your normal Fasacre teeth or your normal practice teeth, and he's done 10 different types of preparations, from a veneer to a onlay to a crown margin with a chamfer, a shoulder, or even for a PFM. And what he's done is he's measured the dust particles that has fallen and quantified, physically measured how much volume of tooth has been lost. And the more invasive the restoration, the more tooth structure you remove. And once it's gone, it's gone. I'm also thinking when I cut a full crown, look at it. It's almost 72% of tooth left. And this scares me. It really does, because we, like I said, we start our life with a natural, full 100% tooth. And let's say I need a crown. I'm 33 years old, and now you're telling me one of my teeth has lost 70% of it. So I have 33 years old, I've only got 30% of my tooth left. What's going to happen when I get older? Now, I know Vietnamese people have a good age life, right? My grandpa is 99 years old, and he is still very fit and healthy. So I know we need to make sure that our teeth last until at least 100. So if we jump in quickly to do a crown, we are accelerating this restorative cycle. We are not thinking about the consequences immediately. But we have to think about the consequences when, let's say I hit 50 years old and I need to redo the crown. And then I hit 70 years old and I have no tooth structure left. So at 70, you're making me get an implant when I had my whole tooth there to begin with. So if you can apply minimally invasive preparations, don't think of crown preparation is the only way, but whether the tooth is restorable, what you're looking at is, can I put something on it, but should I? By you doing this, I will be taking away some good tooth. Will this help the tooth, or will this make it deteriorate faster? So I've spent a long time on talking about tooth structure, but of course we have other factors that I have shown in the flowchart about the restorability. Now, it's not just this, but it's where your margin position is. Are they accessible? Are they maintainable? Are they above the gum? Because once the margins start dropping subgingivally, you're immediately increasing the periodontal and the technical risk. The third thing is cracks, which are often undiagnosed and the things why things fail. The fourth is endodontics. Is the tooth vital? Is it predictable? Are we restoring something that already has a compromised, broken down foundation? And finally is the periodontal support, because we can build the most beautiful restoration, but if the supporting structures aren't stable, it just won't last. I will braze through these aspects because I think Dr. Luke and Dr. David have gone through such a good job with us this today. But the only other thing is, I'd like to say, will this tooth actually survive function as well? I'm thinking about this tooth under load, under its occlusal, and I'm also thinking about a few things is it in a favourable position? Is this tooth vital for my treatment? Vital for, let's say, a 12-year-old who has still going through their growth spurt? And how does it fit into the overall mouth? So we bring it down to all of this together, and what we're really talking about is risk. Our job isn't to eliminate the risk, because everything we do has risk. But our job is to recognize it, to understand it, to tell the patient, and to manage. So this chapter is, once you start thinking in terms of risk, your decision-making changes. You stop treating things the same. And you have to start tailoring what is in front of you. And so, like I said, this patient has generalized wear. Underlying cause, poor quality of saliva from medication, his diet, he has a lot of lemons, his parafunctional habits. So this becomes pathological wear. Pathological wear is when there is significantly more tooth structure lost than you would expect for a person of his age. And we're immediately thinking, before we even do restorations, he is high risk. So we've got parafunction, we have high erosion, and we've got medical, so he has some xerostomia, he has some acid reflux. His compliance, I don't know yet because I have just met him. How good will his compliance be in 5 years? His caries, well, he's got some caries and he has some poor saliva. Look how many red ticks there are. He is very high risk. So the priority here isn't just to put crowns on him. We need to make sure we educate him and we know what the effect of our treatment will be. So then we're thinking about our treatment plan, and we have so many options of what we're going to do. But the treatment risk, particularly for a higher risk patient, isn't what we do next, but is what is the risk in what we are going to offer them. So how complex the treatment we're going to offer, what are the patient's expectations, the consequences if they have complications, how easy can we fix it if things go wrong? Difficulty if I need to fix it in the future. How much is it going to cost us? And lastly, Have I just done them irreversible damage, or do I have options in the future? So this is our risk. And no treatment is safe. They can just carry different risks. Because where it becomes powerful is this understanding of the risk assessment, is that we can then move into phases like we can stabilize and we can then start to rebuild. But there's also one more critical factor. And as our speech pathologists Janella and Vanan said today about PROMs, patient-reported outcome measures, this is so important. Because all of this diagnosis, this risk, the treatment options, means very little if the patient doesn't align with what they want. And we are actually starting to do research about patients in the literature and how to help that in our everyday clinical work. So every patient has different goals. Some want longevity. Some want just aesthetics. Some want something that is simple, affordable, and minimal appointments. And some goals don't align with what we think our ideal is, but you're balancing now a lot of different components. What the patient is expecting, what their function will be like, what their biological can handle. And this is where communication becomes critical. Because your role is not just to diagnose, but it is to also treat through all those risks. So a good prosthodontic plan isn't about what works today, but it's what will work when the plan goes wrong. So let's go back to our gentleman from the beginning. And this is where the patient's goals become critical. He is 75 years old. So the question is, what can I do and what will make sense? Each tooth gets deconstructed. The pulpal status gets conducted deconstruction. So we test the CO2 positive pulp. We want to make sure the endodontic response is good. We do a perio chart. We make sure that the gingival health is good. And then we're talking about taking and seeing how much tooth structure is left underneath. And this will give us a good, guarded, or high-risk scenario as to what to expect for each tooth. I do this for all the maxillary teeth. I do this for all the mandibular teeth, particularly if you would like to do full mouth rehabilitation. Now you can see I have put the two laterals as guarded, which means I am not expecting this person to die with these teeth. The other teeth have a good chance, but these two laterals, you see how much tooth structure remains? It remains very poor. So my treatment plan would be eventually to replace those laterals when they do start to fail. So the perfect treatment option for this patient, of course, can be dentures, can be bridges, can be implants. But what I tell the patient is it doesn't have to be one option. It can be modular. And he may need a bit of all of them over time. We can extend different parts of the treatment phase, we can delay certain decisions, and we can move between all our options. For example, if he chooses, I've had enough, I want to take all my teeth out, I want to go for full implants. I have to be very clear to him that if it fails between 5 to 10 years' time, I've even seen some full arches fail, at the 5-year mark, 1 year mark. But if we're lucky, we get 15 years. He's often left replacing that with then full dentures. So if you are not willing to go for full dentures now, please have in the back of your mind that should things fail, that might be your option. It is not a lifetime solution without consequences. Whereas he can choose to maintain what he has now and transition to implants when things fail. And should they want to do implants later, they have that option. So the goal isn't just to push one stream of options, but it's to educate him to keep his options open. So there's no perfect solution. There's only informed choices of what to make. In the end, we decided to do a combination of composite resin crowns and a denture. I actually didn't end up crowning those laterals because they were too fragile. But we go back to our decision making. We said that he was a high-risk patient. Remember, he came in, he had a lot of red against his name. And so if he's high risk, the treatment that I would like to offer him should bring down his risk pathway. By providing him with a denture, it means that it is easily maintainable. Should anything go wrong, a denture is relatively easy to maintain. So we are moving his high risk down so that the treatment that we offer him becomes medium, and then the overall risk profile of everything we do becomes a lot lower. So I'd like to end with my tips for success in prosthodontics. And it comes down to just don't treat every tooth the same. Okay? Don't treat every tooth the same, and tailor the tooth preparation to the individual tooth. The second tip is to have a backup plan. A, keep the tooth. Plan B, what if it fails? What happens next? Everything will fail. Not everything, but enough of your parts of your treatment might fail. But if you haven't worked it through in your mind as to what happens when it fails and what you're going to do, you may be caught out. So often the best plan is the simplest plan. Take the time to find out what the patient wants and what they wish, their motivation. Not the most complex or the most expensive or the most impressive. The one that the patient understands and they can maintain and it aligns with them. Because if you don't take the time to understand their motivation and their expectations, you may have a perfect plan on paper, but it still won't work. And every case and every restoration has a consequence. So from my hometown, this is the University of Western Australia. I'd like to thank you very much for staying this afternoon and listening to me. And it's been an absolute pleasure. Thank you very much.
Thank you, Dr. Steve, Jennifer và Minh Song. Cảm ơn bác sĩ Minh Song. Now, please welcome to stay Dr. Đăng Ngọc to give a flower and certificate to Dr. Minh Song. Cô Minh Song người gốc Việt, cho nên cô có thể hiểu tiếng Việt được.
Oh. Sống Việt Nam đồ ăn rất là tốt, ở ngoài cô sống
Dạ, xin quý vị cô một tràng một tay thật lớn để chúng tôi có thể có vui ạ. Bây giờ là cái phần mình có một thời gian để cho một số câu hỏi và đáp á, thì không biết là quý thầy cô và các bạn chúng ta có câu hỏi dành cho 9 báo cáo viên trong nguyên ngày hôm nay ạ. Now time for Q&A. So if you have any question from to our respected speakers today, please raise your hands and let you know. You can raise question in Vietnamese, and our translation will translate your question into English. Yeah, please. Tức là các thầy nói rất dễ hiểu quá rồi, không còn câu hỏi nào để hỏi hết. Thế là bây giờ là bắt đầu não nó đang chuyển về không khí của chiều thứ bảy rồi, không muốn suy nghĩ thêm nữa. Yes, if no question, it means because all our speaker is very clear presentation, very clear explanation, something like that. So you have no question in your mind. Or now is the maybe time for weekend. You don't want to think, to do more thinking about create any question to our speaker. So any question for floor? because both of our speakers they has their own emails. So if you have any question and if you feel a little bit shy to raise question in this plot, in this hall, please send a question to us, and we are very happy to transfer your question to our speaker. It's okay. Yet, if you have any question, so once again, thank you. Before we closing this session in this afternoon, on behalf of the organizing committee and especially on behalf of the faculty of odontology from South Medical University, is also on behalf of the National Hospital of Odontology in Ho Chi Minh City and all our college students. We would like to thank you very much for your hard days. On speaker from Australia, Vietnam Dental Health Project. I think you now on speaker order to bring away the new ways, the new thing from the update technology, that knowledge, not only from our college but also from our final years speaker and final year students. And the lesson today maybe will get more useful and benefit from especially for our final year students before the final examination happen in next month. Yeah. Of course, my colleague had an opportunity to be updated the new many fields in identity today, especially in this afternoon. So I think we are very looking forward to see all of you in this process any years to be in National Hospital of Odontology in Ho Chi Minh City and to be our university for our annual scientific meeting. I think Dr. Chang and the key leader from the university also very happy and pleasure to get maybe the workshop every year integrated in our annual scientific conference at the Fountain Medical University. So thank you very much, and I hope you are very happy and live tireless. But I think you feel pleasure with a lot of our students, a lot of our colleagues to be inside this until today. So I also let you know we got this big conference. The first conference happened in the new campus. So we a lot of things because facility, teaching facility, research facility is so new. And sometimes I have some maybe the technical problem happen during your presentation. So we really apologize that you see for time, and we hope we can improve more for the next conference. Once again, thank you very much. Yeah. Một lần nữa thì xin cảm ơn tất cả quý thầy cô, quý vị khách quý, quý đồng nghiệp, các bạn sinh viên. Chúng ta đã có mặt đến đây để suốt một ngày tại trong cái hội nghị mà tích hợp với là cái hội nghị của toàn trường, và tôi nghĩ là cái hội trường này là hội trường đông nhất trong cái hội trường đến tận giờ này, và cũng nhờ các bạn sinh viên chúng ta đã có mặt để đây là một cơ hội rất là lớn. Chúng ta được học không phải những thầy mà những thầy rất là lớn, và hy vọng là các bạn sinh viên có một cái trải nghiệm thú vị trong cái ngày hôm nay. Và cũng là đây là một cái hội nghị lần đầu tiên mà tổ chức tại campus mới, có nhiều thứ lắm. Thì mỗi bạn sinh viên chúng ta phải dùng chung một cái tay để biết là mình ngồi vào cái ghế, mình biết cái ghế này có rất nhiều công sức và mình phải cố gắng bảo vệ, bảo tu, bảo trì để những thế hệ đàn em phía sau của mình còn được học, được tham dự, được ngồi trong cái hội đại một cái giảng đường rất là hiện đại và rất đẹp như vậy. Để kết thúc cái buổi này thì xin trân trọng là chúng ta sẽ có cái hình chụp mà tôi nghĩ rất là có giá trị, là cho chúng ta chụp hình chung với tất cả báo cáo viên và các thầy cô và các bạn thầy cô ở cả hai tuyến là khoa học mặt ở khoa phòng thật, bệnh viện răng mặt trung ương và với là các cái hội thảo viên, và chúng ta có một mô hình. Thì để xét được cái mô hình đó thì chắc là các bạn di chuyển ghế, sắp ghế ra phía trước, thì chúng ta có một hàng ghế để cho các thầy cô báo cáo viên ngồi và các thầy cô lớn trong khoa và hai bệnh viện ngồi. Sau đến hàng ghế tiếp là các thầy cô hội thảo viên, rồi sinh viên chúng mình phải cố gắng làm sao là hàng quỳ hàng đứng miệng sao là chúng ta